And today we have a great privilege of going to the wonderful state of Utah, Salt Lake City, to Dr. Rajiv Iyer, who is an assistant professor of neurosurgery and orthopedic surgery, and a spine surgeon who's later going to talk about untethering the spinal cord, identifying this pathology, and some more recent advances as to how to do this. Just a sound check here. Rajiv, are you live? Can you hear us?
Yes, Dr. Shepin, how are you?
We are great, and we see you well. Is there snow outside your window? No, it's just
no, it's 70 degrees here in Utah, so the snow's all gone and it's flooding the place.
Okay. Well, you look great, and thanks so much for joining us this morning. We always start with some cases, but before we go into those, I want to first of all thank our audience for joining us around the world. We have a very nice attendance, and please know that our videos and sessions are all recorded on ssfyoutube.org. And self-declaration, a little advertisement in our own matter. This Saturday, May 20th, we have the 13th All-Star Radiation Oncology, Neuroradiology, and Spine Surgery faculty joining us together for the multimodal treatment of spinal tumors, led by none else than Dr. Ehud Mendel from Yale. So it's a great occasion to kind of beef up on all the various aspects of advanced spinal tumor care, something that we see and are confronted with virtually daily. So Rajiv, if you have nothing better to do this Saturday, please join us virtually. And it's a very cool group, and the QR code to access this will be shown at the end of the STED talk today. We've, as always, assembled some cases from our fellows who are a wonderful crew. They're coming to the end of their academic year, and we've put together some spinal cord anomalies and also some challenging spinal column things, so we all can kind of share in the knowledge. And Rajiv, if we may, we'll ask for your opinions and thoughts as the presentations go on.
Of course.
And we'll lead off with Dr. Schlaudroff, who has a case that he recently was involved with, and we'd love to hear your opinions and see what the audience has to say worldwide. Thanks, Abe, for putting this case together.
Hello, good morning. So this actually is a fresh case from last Monday. It was a 20-year-old female who had 4 years of neck pain, predominantly right arm radiculopathy, but also bilateral upper extremity numbness, paresthesias, and a little bit of myelopathy symptoms. She was a college student, and about 6 months ago had acute worsening, and sounds like suddenly had maybe tetraplegia, which rapidly resolved. And she came to us a couple times to after she got her imaging to discuss kind of further care, and with acute worsening, that's when we decided to operate on her. She tried a lot of conservative measures such as therapy. You can see there on physical exam, essentially she has a normal exam, full strength, normal sensation, no clonus, no Hoffman's, no hyperreflexia. Here on her imaging, you can see a sagittal on the left, T1 with con. On the right, a T2, and then on the top on the right side, axial cuts, a contrasted, and then a T2.
Rajiv, if I may interrupt. So this is a 20-year-old patient, and she has had a normal development, normal family history and everything, Abe, until this event?
Normal citizen.
Yeah.
College student.
No genetics. And what does she study again? What does she do? Do you remember?
That's a great question. I'm not sure.
But she is scholastically advancing well, has no issues with anything?
Yep.
Wow. Okay.
Yep.
So, Rajiv, tell us when something like this occurs, we have a sudden neurologic event, and obviously everybody nowadays gets an MRI scan. What do we do? How should we respond as we see this? Do we do just an MRI scan of the C-spine? Do we look in other regions? Tell us a little bit about what you teach your fellows and residents to do.
Sure. Yeah, well, it sounds like a lot of her symptoms localized to the cervical spine. This has been an issue for some time. I think it's important not to get tunnel vision when we're dealing with a lesion that's intramedullary. It could be different things. Some of them are neoplastic, but it's important to consider other etiologies as well, such as vascular abnormalities or inflammatory abnormalities as well, because some of those involve the neurosurgeons and orthopedic surgeons, and some of those involve neurologists as well. So I think it's really important to study the images carefully to get a sense of what's going on, especially over time. If there are serial images, I think it's important to understand whether something's intramedullary, it's expanding the spinal cord, is that progressed over time? Has that gotten bigger? It looks like there's a T2 hypointense cap around this thing. Does that represent blood? Was this sudden onset event perhaps a hemorrhage of this lesion? And so I think that there's different things that come to mind there.
So in terms of imaging studies, so here we have an MRI. Do you want any special sequences? Do you insist on contrast? Let's say you got a regular MRI scan without contrast. Do you insist redoing it with contrast? Do you want to look at the brain and all parts of the spine routinely?
I think it depends, especially I think you're alluding to the fact that this patient has an intramedullary lesion, whether they may have something like neurofibromatosis, NF1 or NF2. And I think it's worth doing a pan-neuraxis image at that time. Isolated lesions in the cervical spinal cord, I'm not entirely sure whether it necessitates pan-neuraxis imaging, but I think in this day and age, for example, any child that's coming in with any brain tumor, regardless of the location, whether it's in the sella, the posterior fossa, we're getting pan-neuraxis images. And I think it's probably worth doing it. And so in terms of what images, I definitely would like to look at a pre and post-contrast T1 and T2 scan. Those are most important. If we're sophisticated enough to do things like GRE sequences, which are more popular kind of in cranial imaging, and I think that's helpful too sometimes.
Are there any lab tests that you'd like to have seen drawn that you'll ask for right away when you see something like this?
I think depending on the history and what the images look like, sometimes it's not unreasonable to look at an ESR, CRP, some inflammatory markers to get a sense of how those things are looking. I think those things.
Now, one big difference of neurologists relative to surgeons is that neurologists like to do taps, and you mentioned a couple of pathologies that might benefit from a tap. Is that something that you routinely will endorse? Like in this young patient, would there be a lumbar tap suggested, or is that just a specialty difference?
Well, this particular lesion is, if you go back to that, it's, the things that we're trying to rule out include something like a transverse myelitis. And I think that it's important to get the neurologists involved to look for, I believe it's oligoclonal bands in the CSF. And so, the thing that we don't want to do is to do a high volume tap, I think, in situations where we think that CSF could be obstructed. That's just one consideration. If there's a downward kind of vacuum effect, a negative pressure for something that's kind of high up in the cervical spine. So depending on what the neurologists say, I think a low volume tap would be reasonable.
So you'd routinely ask for neurology to consult on a patient like this?
I think it's important. I think
Oh, wow.
we just need to make sure that we're ruling out something in the spinal cord that's not sort of neurosurgical.
Now, Dr. Sloudorff came from UPenn, so from Penn State. I always make that mistake. From Penn State, I apologize very much. I'll learn it one of these days. What would your protocol be? Would you do a neurology consult? Would you get a tap on a patient like this?
I think the one thing that we probably would have done is maybe do like a spinal MR angiogram. We would do like a whatever type of sequence you have with your machine, but to look for some type of abnormal vasculature. As far as lumbar puncture, we probably would also do a lumbar puncture with neurology. I think it's institutional how helpful they are. I don't think they would have added much where I trained. So we probably would not have gone a neurology consult, but we probably would have gone probably CT, which we didn't get, and then some type of angiogram, probably an MR angiogram, not a formal digital subtraction angiogram, but just an MR.
So an MRA. Rajiv, MRA versus selective angiography, would that be something that you'd want to have before you make further treatment decisions?
I think an MRA is useful. Yeah, absolutely. And depending on the institution, like you were alluding to, and the quality of the study, I think that's a good first step to get a sense of what's going on there. If it is something like a cavernous malformation in the spinal cord, intramedullary cavernous malformation, it probably would be angiographically occult. So I think starting with an MRA is very reasonable.
So you mentioned a couple of differential diagnoses. Is it fair to ask you what your top three are in sequence of likelihood of preponderance?
On that T2 cut, and it's a little small on my screen, I'm sorry, but from what it looks like to me, It does look like there's a T2 hypointense rim around this, almost like we would call it a popcorn lesion in the brain. It could be that, a hemosiderin lined rim around this lesion. And so the thing that comes to my mind is a cavernous malformation, an intramedullary cavernous malformation. Other things on the list, given the patient's age, if this is a neoplasm, probably we would switch from the pediatric sort of demographics into the adult demographics, given the patient's 20 years old. And in that situation, ependymoma would be highest on the differential in terms of intramedullary spinal cord tumors with pilocytic astrocytomas or other types of low-grade gliomas that are glial, astrocytic would be a little bit lower on the list.
Mm-hmm. And as the initial management, so we saw that this patient had kind of an acute cord pathology. Would you endorse steroids? That's obviously always the neurosurgeon's, the spine surgeon's best friend. Would you be okay with a good old IV bolus of steroids, or is that not cool?
I think it's cool. I think I would do it.
It's okay?
Yes.
All right. So Abe, we heard a great differential diagnosis. I think that resonates heavily with what you all thought. Take us a little bit further.
Yeah, so expansile cord lesion, our differential was, like you said, some type of intramedullary tumor like ependymoma, astrocytoma, or cavernous malformation, especially because there's a hemosiderin room there. So we end up doing a LAMI, open up the dura, and I try to get some photos of the microscope. It's hard to tell, but it looks like there was a bunch of almost like arterialized veins once we open up the dura. Concern for maybe arteriovenous malformation. Did not look at all like any type of intramedullary tumor.
So basically a durotomy was done. Was it an expansile duroplasty or?
Oh no, we opened up the dura, examined it, saw that it looked like it was highly vasculature and didn't look like a tumor, but looked like some type of vascular lesion, either cav mal or an intramedullary AVM. And
so you left that lesion alone?
Oh, that's the question. What do we do?
So,
do you try to resect it, or do you?
Rajiv, what should we do? So here we are in the OR. A decision has been made to perform a laminectomy, right, or a hemilaminotomy, or
laminectomy,
a full laminectomy.
Laminectomy. Open up the dura.
C5 to 7, or what was 11?
4 through 6.
4 through 6. Yeah. Okay, 4 through 6. Laminectomy was done. A midline durotomy was done.
Yes.
Midline durotomy was done, and we're now seeing a vascular type lesion. Did you have an MRA beforehand?
We did not have an MRA.
No MRA was done beforehand. Okay. So the images are of low resolution, sadly. If you can go back, what are we going to do now, Rajiv?
Yeah. Well, I think that for starters, for a case like this, laminoplasty or laminectomy high up in the cervical spine around this lesion, I would consider utilizing D-wave potentials as well. Just to monitor corticospinal tract function, in addition to standard neuromonitoring with SSEPs and NEPs. I think ultrasound is one's friend here as well, to make sure that we're centered about the lesion, that our bony exposure is adequate for that encompasses the lesion itself. I'm seeing a bluish colored lesion that I assume that the operator is on the left side of the patient, or perhaps not. There's something eccentric to the side there where it's bluish on the spinal cord itself. The cord is a little bit expanded there. I'm not so sure I can appreciate the arterialized veins that we're talking about here. I think a spinal cord AVM wouldn't have expected it to take on that appearance actually on MRI, but I probably would be a little bit regretting not having some type of vascular study at this point to confirm that, because there's there's a bit of a difference in terms of how those two things are managed, at least in terms of the surgical approach. And so, I think you're there. My leading suspicion is a hemosiderin rimmed cavernous malformation. And I think that if we have good neuromonitoring and we have our exposure here, it looks adequate. I think that proceeding with a midline myelotomy and attempt at resection is reasonable.
So Dr. Daly is here, also a long-term friend and co-chair of our annual Spine Trauma Symposium. Thanks for joining us, Andrew. Great to have our colleagues from Utah here. So what are your thoughts? So you get called into the OR by a colleague who's done a nice durotomy. There's no MRA available beforehand. There's an isolated lesion in the cervical spine, pretty large, young 20-year-old patient. Abe, can you take us to with the cursor? Don't use the laser pointer. Yeah, just a brief. So you should take us to the lesion area. No, you have to use the computer cursor.
Oh, there we go.
Yeah, there you go.
Yeah.
So what's this bluish stuff that
So
Dr. Iyer
midline's
was talking
kind of
about?
like back here. This would be the right dorsal root entry zone here, and then there's this. The lesion is kind of more off the left hemichord. That's pushed the cord over, so it's actually it's ventral to the left dorsal root entry zone. But it's all this stuff here, and it's hard to tell. But there's kind of these several veins that look almost arterialized.
Why do you say they're arterialized? I mean, they just look dark blue, purple to me.
Yeah, they just don't look normal.
Okay. So Andrew, what are your thoughts now? You have this.
I mean, good morning, Jens. How are you? It's good to see you.
Thanks.
My thought is still a more common pathology would be a cavernous hemangioma, or CAV-MAL, excuse me. And that's what I would be treating this as. I mean, intramedullary spinal AVMs are exceedingly rare and usually very, very dangerous. It would be nice, given the original pathology, to have had a angiogram, but since we don't have that, I think we're going to be left with the diagnosis of CAV-MAL. I don't appreciate the arterialized veins. I think I would, the question is, would you approach this through the dorsal root entry zone or through a midline myelotomy? I'd have to look a little closer at the axial images, the axial MR images, and might go through the DRES in this one because it seems to be unilateral, more unilateral to the left.
Okay, great points. Abe, tell us what was done.
So we called in our vascular surgery colleagues and discussed with them, and they agreed to close up and do an angiogram, just because they thought it looked like an AVM. We did an angiogram, and it was actually negative, so spinal angio negative. So it was CAV-MAL.
So what do we do now? So we've done an exploratory durotomy. We have a malformation, but no AVM. What do we do now?
So plans take her back to the OR. This has all happened within the last week.
So now we're taking her back, and what are we going to do with the vessels? Extirpate them?
Resect it.
Resect it. How bloody is it going to be?
Shouldn't be too bad.
Any further preparatory things to do?
I don't think so. I think all the correct studies are done. Now we know what it is. And
Rajiv, indications for hardware in this kind of a situation. So she's had a laminectomy done. Would you fuse a patient like this?
Did you say it was a 3-level laminectomy, Abe?
Yeah, 4 through 6.
I think it's also reasonable to keep the patient in a collar post-operatively and observe them. It will add some time to a reasonably complex operation. And I think that staging that would be appropriate if needed. And I think that's something that we can watch over time, But a 3-level laminectomy in the cervical spine, post-laminectomy kyphosis would be a concern. Which is why I think sometimes in these situations, one could consider as well doing a laminoplasty, especially with something like an ultrasonic bone cutting device with replating. So. But I wouldn't necessarily fuse up front, Dr. Chan.
Yeah. What would you do differently now? Could this patient have been treated in a single stage? Would the angiogram have helped greatly beforehand, just in retrospect?
I think in our retrospective scope, it may have been useful to have the angiogram or perhaps a CT angiogram of the cervical spine or an MR angiogram, just to have some sense. But I do think that the lesion, and I appreciate Dr. Daly's thoughts as well, that a spinal AVM that's intramedullary is quite rare. This lesion does have the appearance of a cavernous malformation on MRI.
So your thoughts in retrospect? Abe?
Yeah, my instinctual thought was there was a cavernous malformation when I originally saw it. Yeah,
Anything you do differently? Would you get the angiogram in retrospect, or
I think it would
MRA?
have been a good idea.
Yeah,
It would have been
okay.
helpful.
Great. All right, we'll possibly show the case later again once you've treated her. Is there a plan to fuse her also, or no?
No plan for fusion.
Okay, great. Well, thanks, Abe. And Abe is going to go on to Idaho, and he's going to be in a major city there. We have another case, and that is, I think, Dr. Jim Hicks is going to show the next case. Dr. Jim Hicks is from the University of Alabama, and he's going to return to Alabama. He's done a great job. It's been a pleasure to have him here. And he's going to be practicing in Mobile, Alabama.
Mobile, indeed.
And Andrew, he's a disciple of the wonderful Dr. Steve Tice.
Indeed. All right, so let's jump into another STED case.
Can you speak closer to the microphone, or bring the
All
microphone
right,
closer?
got it. So Miss B, she's 35, history of low back pain for 2 years now. Also has complaints of some imbalance, which is a bit of an odd story, but she is aggravated by sitting for long periods of time, and when she walks, she feels she leans to one side at times. Her symptoms are alleviated by changing position or lying down even. She does have a history significant for a detethering approximately 10 years ago, and possibly another surgery prior to this for what she quoted as her scoliosis, but is unsure. All right, diving into her examination. She does have some long track signs. She's hyperreflexive patellar, Achilles, and quadriceps reflexes, and she does have a mild amount of clonus bilaterally. And these are her original images, part of her Scoli films when she shows up here. And something to note is perhaps the interpedicular widening, and they can see if you look closely around the lower thoracic and into the upper lumbar spine on the AP. And then I would just, in terms of a orthopedic point of view, when you see a rather odd upper thoracic curve, makes me think about just getting an MRI, and we need to look at this further.
Do you mind just using the proper cursor to show us the upper thoracic curve that you're mentioning, then the interpedicular widening?
Well, the lower thoracic, you can see where you do have some widening of those pedicles,
So
getting out towards that periphery of those bodies. And then the upper thoracic curve, to me, just looks very, very odd and worthy of further imaging. And so, just a couple cuts from the MRI. You possibly can see some ectasia here, but also really almost a septum in the division of the spinal cord in the lower thoracic spine here. And then we progress downward. And again, you can see the essentially two cords, lower thoracic into the upper lumbar, which does rejoin at the lower end around L5, actually. So she has a very, very low conus. Pressing onward, this is the lower portion where the cord actually does rejoin, and then at that low conus. And just an interesting case that we saw in clinic and was worthy of talking about.
Wait, let's go back. Let's go back to some of the cord images.
Sure.
So, Dr. Iyer, so what is this? I mean, James gave it away a little bit with his slide, but what is this and what are concerns? This young lady has obviously had a major laminectomy done. She literally had her whole back slashed open. She's a relatively large person now, but she enjoys a pretty normal life. So, and she was sent to us for correction of her cord anomaly and some vague back pain. So how do we approach this kind of a patient, and what questions should we ask? What should we look for?
Yeah. Well, it looks like this is a split cord malformation. You can see that there's, on one cut on the left-hand side, it looks like there's one dural tube that contains two spinal cords. And on the right-hand cut, it looks like there's two dural tubes in which there's two discrete spinal cords and two discrete fecal sac. And so that's quite interesting. It's almost a combination. There's a type 1 and a type 2 split cord malformation. A type 1 classically features a bony septum that splits the two dural tubes. So that's how I remember it, is a type 1 has two dura, but a type 2 has one dura with a fibrous septum. And so it's different in this patient because this seems like a post-operative MRI. And so someone's intervened on this patient already, presumptively for an initial untethering operation many years ago, which is my alarm bells were ringing when you showed the first X-ray. Number one, because there's a left-sided thoracic curve, which is an atypical curve. And number two, because if there is truly spina bifida, which is a bony non-union in the midline of the posterior elements, it typically extends down to the end of the spinal canal. And this was more of a focal splaying, suggestive of the laminectomy, not spina bifida. But having said that, this does represent a tethering lesion, but tethered spinal cord is a clinical diagnosis, not a radiographic diagnosis, although there are many tethering lesions that show up on imaging. It's important to understand how the patient's doing and faring and progressing over time, which is, I believe, what you were getting to.
So yeah, so I think that's a very erudite description. I know you'll go into that later, and that's a very important point to make right there. It's a clinical diagnosis of tethered cord. It's not a radiographic one necessarily. So there's a substantial pathology present radiographically, imaging-wise. And I don't know whether that helps you to have that coronal image. I thought that was pretty telling there. What questions should we ask this patient to see whether there's a clinical diagnosis of an ongoing tethered cord present?
I tend to group the symptoms into categories. Number one being pain symptoms. And so are they having worsening back pain? Sometimes the patients will describe it as a pulling phenomenon in their back, especially as they bend forward, a tearing sensation in their back. Another is lower extremity pain. Are they having any radicular pain or painful dysesthesias? So that's another component to this, is sensory complaints, so numbness in the lower extremities. And all of this kind of alludes to how a patient's mobility is doing. And so I would ask specific pointed questions about that, because sometimes this is a slow growing process. And if you ask a patient one day and ask them again in a week, there may not be a big change. But if you ask them, could you walk the length of a football field or go to the shopping mall or go grocery shopping a year ago and now tell me about your functioning, I think sometimes that can elicit some findings there that are important to recognize in terms of a patient's mobility and stamina. And then finally, urological symptoms as well. So, are they emptying their bladder completely? Have they had any urinary tract infections? Any signs that anything is going on with their urological function? Some other symptoms that I think are associated with tethered spinal cord that we don't talk about as much are constipation. So any changes in bowel function. Spasticity of the lower extremities, so they feel like their muscles are tighter in their legs and it's difficult, tight hamstrings and the like, or in their ankles. And then finally, scoliosis progression, although that's somewhat controversial. And I believe this patient was mid-30s, so I'm not quite sure. Generally speaking, I would consider that to be a sign of tethered spinal cord in a skeletally immature patient.
Would you consider CT myelogram? And what about urodynamics? If the patient's answers are kind of a little equivocal, should we have some numbers to kind of go to the urologic functions?
Yes. There's a lot of subjectivity with urodynamic testing, and it's institution dependent, but I do think that it would be very reasonable to have a baseline when I evaluate this patient, have them see urology, get a sense of their bladder function, if they had any UTIs, and just establish a baseline, especially if one's going to consider doing an operation on them, not necessarily at this moment in time, but perhaps down the road. You can always compare back to a baseline urodynamic study and see if there's been any quantitative change in things like bladder capacity and pressures.
And to be concrete, for urodynamics, are we talking about post-void residuals? Are we talking about a bladder EMG?
I believe the term is a VCMG.
Yep.
We're probably talking about the same thing there, looking at bladder tone, sphincter, detrusor function, and whether there's a synergistic kind of contraction and emptying of the bladder, which also will measure post-void residuals.
Great.
Very good.
Andrew, should we get a CT myelogram? You know, I like CT myelograms. We frequently debate that for my deformity patients. Is it worth getting a CT myelogram on this patient?
I'm not sure a CT myelogram is going to add that much. I would certainly get a CT scan because I want to see if there's still any bony bar or anything that is left there residual with the diastomatomyelia. So I think a CT scan is imperative, but not necessarily a CT myelogram.
Great. All right, James, tell us a little bit about what you have put together next.
Right. So in terms of her, her symptoms were relatively mild, and so we chose to observe her for a while. But in terms of getting into diastomatomyelia, it's a congenital condition with a bar, and again, we mentioned the need for a CT, look for any kind of bony septum or longitudinal cleft, as mentioned here from ortho bullets. But it typically does reunite distally, so something to look for is that low conus, which we identified. There's a scoliosis in the majority of these patients, and something to note is lower extremity deformity, in particular in the feet. You can have presence of a clubfoot or a history of it, pes cavus, other foot deformities. So something to keep in mind. That's all I have.
So she's a diplomyelia patient then, technically?
She had that very low reuniting, but as mentioned previously, it is somewhat of an odd type 1 to type 2. So I'd still say maybe it's still a regular DM instead of the diplo, but we'll.
Did we get a CAT scan? I thought we had ordered a CAT scan.
I believe there is one in the chart. I don't have it uploaded here.
Okay. So Rajiv, if you go back to the scoliosis x-rays, what do we do with this young lady? She comes to us from LA. She actually had a very prominent name in orthopedics. Treat her in the past when she was a young girl and give her this laminectomy, which basically, I mean, her incision goes from the interscapular area to the pelvis. She's become pretty large. She seems to be a happy person, actually. She is, I believe, married, and they go hiking on weekends. So what do we do with her now? Do we tell her surgery? Do we look at things further? I think a CT was ordered. We sadly didn't download it, but I don't think there's any bony bar that I remember, anything like that. So how do we manage this patient going forth?
I think it depends on the patient's complaints, Dr. Chapman. If the patient is getting worse and has progressive complaints like back pain or leg pain, then that's more suggestive of tethered spinal cord. And I think that the zone of tethering, the actual site of tethering in these patients is a little bit conceptually odd to me. I don't have a vast experience with split cord malformation and untethering these patients. But either the fibrous septum itself could be the site of tethering, or other sites, or the patient's had surgery in the past. I would really want to see what those operative notes have detailed. Was it just a laminectomy? Was there an intradural exploration with an untethering? Was it an extradural removal of a bony septum here? All of these things I think are really important, because if there's been a previous intradural surgery, it raises my suspicion that there could be a component of arachnoiditis and scar tissue, which could lead to recurrent tethered spinal cord. And so I would want to know all of these details before proceeding. And I think that one of the most important things for a patient like this is that this is probably a complex surgery. And this is sort of on the spectrum of tethering lesions. I think this falls on the more complex end of that spectrum. And so I would have a fairly high threshold to intervene. So I think following this patient over time makes sense. The back pain could be due to tethering. The back pain could be due to other reasons. It's reasonable to enroll the patient in physical therapy, get urodynamics, and see them back in a few months to see if the curve's progressing, although it's not a very significant curve. And so kind of get a sense of how things progress over time.
I think we have a great concurrence of thoughts. We did order a CT, not a CT myelogram. We did get a phone book when we asked for the past records. One of those, for the older generation, they had these things called yellow pages. Before this thing called internet came around, they were the collective phone knowledge, phone tree knowledge of a community. So we got a huge disorganized stack of papers from the patient. We asked for past records, and from what we gathered, she had been in the hospital for over 3 months after her laminectomy because she had a wound breakdown, she had a CSF leak. So this was a battle that they had fought, and she has no ongoing headaches, right, Jim? No real issues. So my assessment was that her disease burden was pretty low. She had mainly back pain. She did have this hyperreflexia, which seemed to be fine, but she didn't have any overt imbalance. She had a negative Romberg's. I think she actually had no urologic complaints, so we did not initiate a further neurourologic workup. But I also got a second opinion with my partner, Dr. Askuyan, who's unfortunately not able to be here, but he looked at it also, and I think his opinion was similar. Just
Exactly the same.
let's not do something. The main thing for this patient was the mental burden. She came in with a significant issue of you need something done because you have a, quote, tethered cord. And she had seen several spine surgical colleagues who told her this needs to be fixed. And this is one of my red flag terms when somebody comes to me and says something needs to be, quote, fixed. We have some fix-it situations in spine surgery quite clearly, but this is furthest away from a fix-it situation. This is a invitation for disaster that I thought would be present. So the mental burden was significant. Now here's a concrete question for her, and I'll ask you and Dr. Daly for answer. She and her husband came, they're very nice people, and they asked whether it would be safe for them to have or attempt pregnancy. What is your answer to that?
The answer is yes. I think that would be reasonable. Yes.
Andrew, do you agree?
I don't see any contraindications to having a pregnancy and having a pregnancy.
I'd concur, but have them meet with a high-risk OB specialist first, obviously.
Great. Yeah, so we have great responses from around the world. Thank you all for joining us. Jeremy Omoro says, again, urodynamics for bladder synergy. I didn't send her to urology. We thought about it, we discussed it, but her symptoms were really so absent that I couldn't justify it.
Right, it certainly wasn't a primary.
As a compulsive baseline, it would be desirable and certainly worth discussing, but after a number of verbal explorations, we just didn't see anything in that realm. We didn't get a defecation study either because she seemed to have a pretty normal function there. So we thought this is an interesting case to just discuss the problems. And again, they came with a great deal of anxiety, promoted by a couple of surgical colleagues. And I felt my main job was to assess her carefully and then calm everything down, because the more I looked into the paper mess, the more I thought this is something that if surgery is done, has to be done with the greatest of thought, because again, her dural sac looked so dysplastic. This would be a very major endeavor to try to keep the dura intact. Fotis Suzanne says, he wants to get, again, a bladder MG to get a baseline. And he justifiably says high likelihood of returning, complaining of worsening symptoms. So maybe we'll have to rethink that, but she's coming back to clinic. We've kind of just plugged her in. Our tentative thought was to get annual scoliosis films until we have a pathway like every 2 to 3 years established, and we'll probably think about the urodynamics a little bit more aggressively. Any other thoughts, Jim?
No, I think it's a great review, especially for me,
Good.
big surgeon.
Thank you. We have one more presenter, Dr. Chris Seidel, and I think he has 2 cases. But thanks for the great discussions. And I think the first case is not so much a curveball. The second case is a little bit of a curveball, and both have the Chapman surgical imprint on them, for better or for worse. So Dr. Seidel is going to return to Virginia. He came to us from Pennsylvania. He's done a great job. And
all right, yeah, so this is a little change of pace, not intradural necessarily, but a bad problem nonetheless. So this is a complicated patient, has an extensive back history and surgical history, 76 6-year-old male. He's a farmer, very stoic individual. He first presented back in 2019 with a kyphoscoliosis. He had undergone corrective surgery for that when he had seen us. Not a whole lot of past medical history that's significant. So these are some representative images from his prior surgery in 2019 showing, prior to 2019, showing his kyphoscoliosis, multi-level degenerative changes you can appreciate here. He has compression throughout the lumbar and even up into the thoracic spine. You can also note that there's a prior T8 compression fracture there that was healed. So in 2019, he underwent surgery for that problem. He had, decompressive lamies. He was multi-level interbody fusions down from the thoracolumbar junction to the pelvis, and instrumentation from T4 all the way down with quad rod fixation.
So before you go further, Dr. Iyer, you're our visiting professor today, but I'll exempt you from criticism of my surgery. This is undoubtedly an aggressive surgical tack. This is taken after due deliberation. Let me put Dr. Daly on the spot. Andrew, have at it. Criticize my work here. I'm not thrilled about the lateral, but what's going on to your read in here?
Should I go back to the original before?
Yeah, sure. Andrew, are you still with us?
Jens, I'm sorry, I got a fire burning here. I've got
Okay.
on.
Are you okay to talk, or should I put Rajiv on the spot?
Ask Raj, because I'm sorry, I missed the case completely.
Yeah, Raj. So I have at it. I treated this patient. I take responsibility for this. Very active person. We had a lot of, I think, a very well-established non-operative case. There's no intradural pathology here. This is a mildly decompensated kyphoscoliosis. There's an underlying inflammatory arthropathy. He had a bone density workup. I think it was okay. He has this T8 wedging. Very active farmer, elderly, otherwise pretty healthy guy. So I did a pretty aggressive surgery on him. I did, after due deliberation, a T4 to pelvis surgery. We left the rostral transition zone intact. Have at it. What did I do wrong in this case?
Well, Dr. Chapman, I think it looks actually pretty good. This is an adult. I'm mostly interested in the kids these days, but it looks like in terms of correction, the main issue that was going on was a thoracolumbar kyphoscoliosis there, right? There was a hyperkyphosis right at the thoracolumbar junction, if I'm not mistaken. And that's a good amount of correction of that. Sometimes in the kids, especially if they have a neurological issue, you want to create the kyphosis somewhere. And so, in terms of matching that to the patient's PI, is there any consideration there in terms of the degree of correction as it relates to the patient's original PI?
This is a very insightful statement. I'm so proud of you as a pediatric colleague that you have used the nomenclature that the adult deformity surgeons like to use, the PI, PT things. Chris, any thoughts? Did I over and under correct this patient in the sagittal plane?
In the sagittal plane, I think we improved him for sure, but I think we probably still have a little bit of a mismatch going on down below, but we definitely improved him from where he was prior.
So there's a little bit of a retroflexed sacrum and the pre-op films, and we've definitely increased his PI.
For sure. Well, not his PI, but his lumbar lordosis.
His PT, and lumbar lordosis definitely increased, and we decreased the thoracic kyphosis. So,
for sure.
Yeah, but he's somehow forward pitched, which kind of bothered me a little bit, but he seemed to be doing extremely well, right?
Yeah, he went back to most of his daily activities pretty quickly. So that kind of brings me to the next portion. So he was, fast forward a year, he's on his tractor, falls off the tractor on the farm and ends up with this injury for which he comes back. This T3-4 flexion injury with fracture and progressive weakness. So this is our kind of next decision point here. Like, what do we do now?
So realizing you're a pediatric surgeon, realizing that Dr. Daly is probably going to be distracted right now. So here we have a neurologic deterioration. The patient was very active. He fell off his tractor, which is not a little lawn mower. It's a very sizable industrial kind of a contraption. So any thoughts of what to do now? Do you take adult call at all, Raj, or are you all pediatrics?
I'm all pediatrics, pediatric neurosurgeon, but you know, at Columbia a couple of years ago, we encountered some of these, and I got Dr. Lanky's wisdom on some of this stuff, and you know, I think at this point the patient's got a neurological deficit. It sounds like, which is progressive and fairly acute. You know, if this was 3 a.m., maybe you give the patient some steroids perhaps and get the team equipped for the morning. But if this patient comes in at 2 p.m. in the afternoon and is having this problem and is sitting in the emergency department, I think it's quite reasonable to take them for a decompression and extension of fusion for this proximal junctional issue.
Let me ask a general. Maybe you have to repeat the question. What do you do with your pediatric cases? Do you put activity restrictions on your long scoliosis fusions?
I'm getting the gestalt of that over the last couple of years, and I think it's a work in progress because I think the pendulums can swing either way, and it depends on the most recent anecdotes that a surgeon's had. You know, I think that it's easy to want to wave one's hands and say you can go do anything, because that's the goal of these surgeries, is to improve someone's function so they can go have a good quality of life. But on the other hand, is too much, and so I think a good 6 months of non-collision sports is reasonable, although that's a controversial statement to make. I think that if you poll 20 pediatric spine surgeons, you'll get many different answers there. And in the adults, I'm sure it's fairly similar. So
you were so insightful to say anecdotal, because I usually try to get patients to all, quote, reasonable activities. And in farmers, that's a little bit hard to kind of quantify, because ladders and power equipment and cool vehicles are part of their lives. And that's one of those things. This case gave me a lot of reason to pause in this regard. Chris, in your home institution, would you have put activity restrictions on these patients?
No, I don't think so. I mean, you design your surgeries for them to get back to life, right? You don't want them to have more restrictions after than they had going in, but you do have to give them time to heal. That optimal time, I think, kind of varies from person to person, surgery to surgery.
So, and I know you do mainly pediatrics, so there's a degenerative constellation of the subaxial spine. The patient has pitched forwards a bit in the subaxial spine as well. Would you think it's reasonable to go up to C2, or would you just try to do damage control and go up to like C7, T1, something like that?
can you show that CT one more time there?
So
You know, with all the degenerative change and all that cervical spondylosis that's present, you know, I think that it's important to try to get this patient through with an operation that's going to hopefully set him on the right path for the rest of his life. I think trying to finesse a situation like this with just a few levels above is maybe acceptable, but given all that degenerative change and there is a mild focal kyphosis kind of in the subaxial spine there. It looks like it's C5-6. So do you stop there? And then is your fixation adequate with the lateral masses? Are you considering cervical pedicle screws with certain, you know, emerging technologies we have available to us? So I think C2, unfortunately, might be the most reasonable place to stop in this gentleman.
It's as if we had choreographed this, right? Go ahead. So we went up to C2, and again, you're very insightful. The patient arrived in the afternoon, I think, and we took him to the OR that night because he was neurologically in a very precarious state, and activity and function is near and dear to this patient's heart. So that was a lengthy surgery, I think, 6 hours or something like that. And we got him into the OR like at 6 o'clock at night, and so we were there until after midnight. But we went up to C2, and he had an anomalous vertebral artery, so we had to actually use a translaminar screw at the top also. But how did you do from that, Chris?
So he was doing pretty well overall for a while.
Go back to that image here from this. So how do you do from this?
He did well from this, yeah.
Yeah, we did 2-level corpectomy in that transition zone. We
Yeah.
basically felt 2 vertebrae were broken. We did a unilateral root ligation. We did not open the whole back. We went to the mid-thoracic spine. We did an addition and went up to C2, just like what you said, to improve his balance. And I thought that we had finally achieved a very nice rebalancing after, for whatever reasons, my sagittal realignment did not work very well. But the saga continues.
It does. All right, so he followed up, 2 years later after that, complaining of low back pain mostly with prolonged sitting and activity as well. And he had this fluid-filled bursa in the lower lumbar spine, but no neurologic deficits. So we imaged him, and this is some imaging we have here showing pseudoarthrosis at 5.1. There's some haloing there of the iliac and S1 screws bilaterally with failure of that distal hardware. It looks like the left iliac bolt has disengaged from that tulip. And so now we're faced with another decision point here.
So this patient, Rajiv, did amazingly well from his extension of his upper thoracic dislocation to C2. I was just so impressed with how he bounced back, and he made a beautiful neurologic recovery. So that late night heroic effort seemed to pay off until, without another real known fracture, he developed this low back pain.
Yeah.
And again, he had returned to an incredible functional status. And again, I identified that he now had a subacute S1-2 kyphosing fracture, so a Denise zone 3, a Roy-Camille at least 2 fracture, or in the AO parlance, an AO type C3, like a sacral U fracture. So a non-union of the lumbosacral junction with the SI joints. You as a pediatric surgeon obviously have to, neuromuscular patients especially, have to think about how to get to the lumbopelvic junction. I think we share this fear and this worry about how do we fix the lumbopelvic junction so that it does not fall apart. Any thoughts on this?
A really challenging situation here. It does look like there's some kyphosis you mentioned at that lumbosacral junction, maybe even within the sacrum. If that's what you mentioned, I believe. That's a really challenging situation. Do you have dual iliac fixation there, or is that?
At this point in time, we just had single pelvic screws, right?
Single modified iliac.
They're modified iliac screws, so not S2AIs. We did single iliac screws, and basically they had loosened on both sides, and the S1 fixation had basically failed, loosened, and the cages had kind of subsided partially.
One thing I would want to make sure is that there's no ongoing smoldering infection that could be causing all this stuff. So if there was a re-exploration, I would have a low threshold to go ahead and culture and just make sure we're not dealing with some type of indolent infection that's causing a pseudoarthrosis at that location.
Absolutely. Yeah, fully agree.
In terms of biomechanically, does one need to consider some type of 3CO right at the location of the sort of S1 region, essentially a sacral dome, in order to bring that back, in order to attain perhaps better biomechanics of the construct at this point? I think that's challenging. That's a big surgery. And I some have utilized BMP within their anterior reconstructive cage. I don't know if that was done here or not. But I would sort of explore and see where the pseudoarthrosis is exactly. Although I guess we could have a sense of that on the CT.
Yeah, so there's a little telltale thing. This patient has an anomalous bony metabolism because this patient actually was on, I think, Fosamax for a while. We put him on either Prolia or we put him on an anti-resorptive agent. His insurance would not pay for teriparatide. So we put him on, I believe, either Prolia or Fosamax. I forgot what it was. But then he broke his femur, and so he had a femoral nail put in also. And that was not from a major injury. So he had actually a almost hyper, or a brittle bone, a hyperdense bone. And I'm not sure that the anti-resorptive agents were what I wanted him to have, but it is what it is. And insurance realities dictates care sometimes, despite all the appeals letters. So here we have a situation. So again, this is a nice video. As he's going through that, Rajiv, tell us again, what would you do then? How would you salvage this from your end? Would you do a sacral U osteotomy, or would you try to enhance pelvic fixation?
I think that in him, he's an ambulator. He's neurologically well, it sounds like. He's got good foot function. I think the risk of a L5 or S1 neuropraxia is real if you try to go for some type of 3CO at the lumbosacral junction there. Although S1 is sort of, it does kind of look, I guess, as you mentioned, fractured in a way, right, anteriorly there, with a focal kyphosis almost at the rudimentary disc at S1, S2.
Yes.
And so bringing that back is almost like a high-grade spondylolisthesis, and there's a high risk of a neuropraxia with those types of surgeries. And so, I think that's, I would counsel the patient well, talk to them extensively about some of the options. You can try to go really big there, but you would need to kind of reconstruct the anterior column with some type of cage at S1, right? But alternatively, if you go from the back and place BMP, make sure there's no infection with dual iliac fixation, I think that's another reasonable option, although it's between a rock and a hard place, I think, in this situation.
Yeah, we decided against an S1-2 osteotomy. I've done a couple of those actually, and those are very complex surgeries. I think you're very insightful in identifying the neurologic injury risk. So we actually went for a lumbopelvic quadruple rod fixation with dual screws. We used, as you can see, fibular allografts to augment the screw tract. That's something that we've done with great success, and one of our former fellows published that. Hossein El Ghafi published that, I think, in Journal of Spinal Disorders, in his experience. And the patient did how, Chris?
He did very well after this. So yeah, I mean, we fused the SI joints as well there, double pelvic fixation now. He did very well from this. Unfortunately, 8 months later, it came back. He fractured his right rod now with some new pedicle screw lucencies down the sacral ala and some sacral insufficiency fractures. And as mentioned, we did have a DEXA on him. It actually did not show osteoporosis, just osteopenia. And he had been on a bone stimulator and denosumab is what he was actually on.
Okay, so he was on denosumab.
Yeah. So, I mean, the question is, what is going on in his metabolic bone health? Is it, is he overloading this with his activity, or why does he keep having these failures?
So these hyperactive patients are a real challenge because, again, despite having, and I've had several of those patients who've had tremendous bone healing, and we've stood on our heads to try to understand the bone metabolism. There are some patients who just keep breaking their hardware. Now, right now, we're just watching him, I think.
Yeah, because he's doing well. He's, back to his normal activities without pain, no neurologic deficit. It's just, we know it's there, so we're just watching.
Any thoughts on that, Rajiv? Are there patients who you just kind of can't keep the hardware intact despite having multiple rods in there and having done a halfway good job at realigning them?
I think the patient looks really nicely aligned in both the frontal and lateral planes. You have great dual iliac fixation, multi-rod construct, crossing lumbosacral junction. I think it's challenging unless there's some infectious concern. I'd be curious to hear more about the denosumab and how that might affect things. But at this point, I think I would agree to continue to watch the patient. Is there a role for SI joint fusion in a patient like this? Is there excess mobility coming from the SI joint itself? Because Dr. Link would always call it a T or C2 to sacrum fusion, right? Because you're not fusing the SI joint. But in this situation, is that a source of mobility that's causing stress on the construct at all? Just a question I would raise.
Yeah, Chris, So elaborate on what we did, actually.
Yeah, it was certainly a concern that we had. So prior on his last surgery, what we did actually was we went in, denuded the SI joint, and we placed a fibular allograft actually into the SI joint and did, a very formal, very robust arthrodesis there before placing our two iliac screws on both sides.
So I perform posterior. I know we've gotten used to from some companies to put hardware across, and I did not do SI joint screws, which are, by the way, not a fusion. They're a stabilization procedure. So we actually did a formal posterior-based SI joint fusion with autologous bone graft, off-label BMP, and fibular strut graft. So we kind of wedge in between the tables and then compress the left to the right ilium with a cross-link. So that was our attempt, and that's actually usually worked quite well, and I thought it had done that. So we're on the same page. We tried to do a formal fusion on his SI joints, but as you can see, there's still some lever arm that is in excess of the material carrying capacity of our 6mm titanium rods. We've gone away from cobalt chrome. So, Chris, we won't have time for your second case, but any other parting thoughts there from your end, Chris? What are you going to do differently? Any learning points?
No, I mean, this is a very complicated case, and you never really want to blame anything on your patients, but I think this gentleman just overloaded his construct several times, and that kind of led to the failure. So this is a great opportunity to introduce our guest speaker, and he's already given us great insights. Dr. Rajiv Iyer is an assistant professor in neurosurgery, and he's dual fellowship trained in pediatric neurosurgery with a special focus on pediatric spinal disorders, and also a further neurosurgery fellowship at the University of Utah, where he stayed on. He did residency in neurosurgery at Johns Hopkins, and again, he trained in New York with Drs. Vitali and Lenke, so he's truly very well trained. And he is, again, one of those dual hits kind of a people. He is both neurosurgeon and an orthopedic surgeon in training, so it's a very cool phenomenon, and all sorts of pediatric spinal disorders are his specialty now. And we're really happy to have him here to talk about a very controversial subject, and that's tethered cord. And I'm pretty sure in clinic later today, we'll have some patients with that particular pathology. Before we go on with him, just a little advertisement. Tonight, we have an evening with a spine surgeon feature, which is quarterly. And we have the famous Dr. Steve Garfin here. He is the chairman of orthopedics at UCSD and dean at the School of Medicine there. And Jack Ziegler from TBI and I will have a 1 hour long chat with him, which is kind of just more about life and insights and reflecting on this great career. We do this quarterly, and we've had great resonance with this. We invite you to participate in this, and also don't forget our 13th annual spine tumor course. With this, Dr. Raj Iyer is going to talk about tethering, the mystery of tethering, and how to maybe surgically approach this. Thanks for being here this morning.
Thank you so much, Dr. Chapman, for that introduction, and it's an honor to speak here with Seattle Science Foundation. As part of this STED talk, I'm just going to load my PowerPoint here. Hopefully that's showing up okay.
Yes, it does.
Great. So again, thank you so much. And today I'll talk about this procedure called a spinal column shortening for recurrent tethered cord syndrome. I don't have any disclosures or conflicts, and the objectives in my short talk today will be to give an introduction to a very complicated topic of tethered spinal cord and tethered cord syndrome, the pathophysiological basis for spinal cord tethering itself, what's the traditional management of tethered spinal cord, and some newer treatment options, namely with spinal column shortening for recurrent tethered cord. And I have to start by thanking my mentors, because I consider these to be the leaders in the field of spinal column shortening who have paved the way for the future. I trained at Johns Hopkins for residency in neurosurgery. So Dr. Nick Theodore and Dr. Mari Groves are some of the goats in the field, I would say, in terms of spinal column shortening. Have published a lot on this, and Dr. Andrew Jay as well, who's a pediatric neurosurgeon at Oklahoma Children's, who's been a mentor to me as well, and has given me a lot of insight and published a great amount on this. Here at the University of Utah and Primary Children's Hospital, I have to thank my group here, Dr. Andrew Daly and Dr. Marcus Mazer, who are outstanding spine surgeons who've been mentors to me. And this has been a group project and starting to take on these cases and see if we can provide some meaningful benefits in the quality of life of our patients. So I wanted to thank them as well. And Dr. Daly's here today. But just to highlight what tethered cord is, it's quite a variable topic. And I thought I would just present a few cases just as a flavor and intro for what tethered cord is. This is a 12-year-old girl with an asymptomatic scoliosis, but it's in the operative range, getting into the operative range beyond 50 degrees. She undergoes a routine MRI. For some will do this, a preoperative intraspinal anomaly check to see if there's anything there. And you can see there's a fatty phylum and a low-lying conus here on MRI. Or how about this one? Here's a full-term baby with a hemangioma on their backside, and you can see a vestigial tail that you can see there. I don't know if you guys can see my mouse at all,
Yes, we can see your mouse.
Great. So there's a vestigial tail there, as well as a low-lying conus on MRI and an enlarging terminal syrinx with fat that's associated with the spinal cord in multiple locations here. So another example. How about this one? 15-year-old gentleman with shunted myelomeningocele, 3 previous direct spinal cord untetherings, and in the past 6 months, 5 urinary tract infections with worsening lower extremity spasticity and decline in function. So here's another example. Does anyone want to go in and operate on this patient for tethered cord with this huge pseudomeningocele that's present there? Here's another example, 18-month-old with congenital scoliosis due to multiple thoracolumbar hemivertebrae, and a fairly thickened fatty phylum here. And the question is, if you untether this patient, does that affect the natural history of the curvature in this patient? And finally, another one, a 4-month-old girl with an asymptomatic lesion on her upper back, a cigarette burn lesion, as we kind of coarsely call them, which is connected to the spinal cord actually through this fibrous tract. 2 terms for this. One may be a non-terminal myelocystocele or a limited dorsal myeloschisis, as some would also call that. So how do we start to frame our thoughts on these various tethering pathologies? And I think the answer first is that we have to distinguish between the tethering lesions themselves and what tethered cord syndrome is. And so, all of this represents potentially tethering pathologies, and these are identified really on clinical diagnosis. And what tethered cord syndrome is a clinical diagnosis that's manifest from abnormal attachments of the spinal cord that results in abnormal spinal cord stretch. And so that results in limited movement of the spinal cord within the canal, and some common manifestations includes the symptoms that are listed here. So back pain, leg pain or lower extremity weakness, dysesthetic pain or paresthesias of the lower extremities. And these upper 3 kind of represent limited mobility and endurance, as we were kind of alluding to in the case conference. Also urological symptoms, and that can include incontinence if the patients are already catheterizing, leakage in between catheterizations, frequent urinary tract infections, and a neurogenic bladder that can be present clinically and also objectively on urodynamic testing. Additional things such as leg deformities were also mentioned. Pes cavus and scoliosis as well has been increasingly thought of as a symptom or sign of tethered spinal cord, especially in periods of growth. And so what are some lesions that cause this? It's quite vast. And so some of these patients have post-myelomeningocele closure tethering, so a myeloplacoid, which can get scarred in, especially as the MOMS trial and fetal surgery for myelomeningocele becomes more popular across the country and the world. Perhaps inclusion cysts are more common, such as epidermoids or dermoids that can lead to tethering. But you can see a whole host of different things here, including phylum lesions, spinal cord lipomas, other things mentioned here. We also talked about split cord malformation today, but also important to understand that certain syndromes predispose to a tethered spinal cord, such as OEIS syndrome, omphalocele, which is also called cloacal extrophy, or caudal regression, and dactyl. So it's important to highlight these patients as well, or post-tumor resection, iatrogenic sort of causes. And so again, tethered cord syndrome is a clinical diagnosis that manifests from these abnormal attachments. And so the diagnosis is based on how a patient is doing. But if you take a patient with spina bifida and myelomeningocele and get an MRI on them, they're always going to appear tethered because the spinal cord is low down in the spinal canal. And so we get these images because they aid us in the diagnosis, such as the presence or absence of a new syrinx. It's good to get updated anatomical surveillance of these patients, but also for preoperative planning and to see where is the site of tethering if we're going to go in and do a tethered cord release procedure. So here, of course, this is an example of an open neural tube defect. Oftentimes when we're thinking about tethered spinal cord, it's in our myelomeningocele population. And so here's an example of an open neural tube defect. And so that's a myelomeningocele, but what we're really talking about is a big umbrella term called spinal dysraphism, which is spina bifida. And the term spina bifida itself means a split in the spine, and that refers to the bony spine. So if there's an incomplete posterior arch, that patient has spina bifida. And there's 2 flavors of spina bifida, one being spina bifida aperta, or open spina bifida, and that refers to myelomeningocele or meningoceles that occur at a certain rate in the general population. And spina bifida occulta is the other type, which is a closed spinal dysraphism, meaning that it's skin covered And there's a big variety of those types of patients, and that can occur even reports up to 10% of the population. And so this, of course, is what spina bifida aperta looks like. 2 pictures of open myelomeningocele, and this is what that might look like. This is a really severe example that we dealt with here in Utah, spina bifida aperta, and we closed this type of lesion within 48 to 72 hours of birth to prevent a CSF infection or meningitis, which can lead to morbidity and mortality. And we place these patients prone. You can see some of these patients there's the open spinal cord, which did not form as a tube. And here you can see that there's this omega sign that's present due to the bony kyphotic gibbus that's present in these patients. And so in really severe thoracic level myelomeningocele, you may see a spinal deformity as well. And so here's an example of what we're doing here. This is an unrepaired defect, as you can see on the left. And this is an illustration from the ISPN guide from Docling Pang that sort of depicts what's going on when we do the repair. The neural placoid is the spinal cord that did not form the tube. And we perform a dissection where we release that from its skin tissue, open the sac of fluid that may contain spinal fluid, free up the neural placoid so it falls downwards ventrally into the spinal canal, and then close the sac on top of that. You can see here what's going on. Here we've identified the normal dura, and we're going to dissect that away from the tissues on the dorsal lumbar fascia, identify the dura, and close that in the midline, that you can see here, the closed dural tube that's present. And then we may or may not involve the plastic surgeons. Certainly for a case like this, we would involve the plastic surgeons to close and create muscle flaps on top of this so that we get good tissue coverage and see how the patient does. And many times they may require ventriculoperitoneal shunt because their spine is open and there's spinal fluid leaking out, and that can affect the rest of the central nervous system as well. And there are various features you can see, such as a Chiari malformation, tectum beaking, a large massa intermedia, things like that. That is a constellation of central nervous system abnormalities with open spinal dysrhythmism. Compare that and contrast that to spina bifida occulta, or closed spina bifida, which is skin covered. You can see various examples of that here. It's a wide array of diagnoses, ranging from just a simple dorsal bony non-fusion or phylum lesions, and it gets increasingly complex with things like terminal myelocystoceles or split cord malformations or lipomyelomeningocele. And so a lot of times in these patients, you'll see some type of cutaneous manifestation of the tethered cord, such as a hairy patch, which is a hallmark and classic sign for a split cord malformation, or the cigarette burn lesions, such as a limited dorsal myelosthesis that you can see on the left. So in these patients, because they're skin covered, you may delay the surgery and you may just observe them over time and see how they do. And so I think a nice analogy for tethered spinal cord is a loaded spring here, or a rubber band that has a certain amount of potential energy and a propensity to recoil if it was released, or gum or taffy or whatever you want to think about to kind of capture that the spinal cord is being stretched out. But what does this really mean for these patients? And I think it's important to understand where we have come from in history and certain seminal experiments that were done. For example, this was 40 plus years ago, understanding the pathogenesis of a tethered spinal cord. So in 1981, Yamada at Loma Linda did some seminal experiments in tethered spinal cord by utilizing what's called a spectrophotometer, a dual wave spectrophotometer, which measures basically the cytochrome enzyme within the mitochondria to see how it's functioning. And so it's a mitochondrial enzyme that's in spinal cord neurons and interneurons. And if you remember back to medical school, it's the terminal oxidase of the oxidative phosphorylation pathway that converts ADP to ATP. So essentially the thing that's creating energy in our cells, in our body, in our spinal cord. And so in conditions of hypoxia, there's a predictable increase in the reduced form of this enzyme. And you can measure that through a reduction or redox type reaction. So this surgeon took 7 patients who had tethered cord, and they agreed to participate in some experiments where sacral laminectomies were performed, and the anesthesiologist reduced the FiO2 from 30% to 50%. And you can see basically we were mimicking conditions of hypoxia. And what happened was, before and after the untethering was complete, beforehand there was an abnormal unresponsiveness of the cytochrome enzyme, indicating abnormal mitochondrial activity. And then once the spinal cord was untethered, you saw an improvement in that response, a more appropriate response to the hypoxic conditions. And then they actually took the phylum and retethered the spinal cord, and they recreated that type of unresponsive mitochondrial enzyme. And so this was sort of some seminal experiments that sort of described exactly what's going on in tethered spinal cord. They did the same thing in cats. They put experimental traction with different amounts of weights on a pulley system, and they induced situations and scenarios of hypoxia. And they found that with increased traction of the spinal cord, there was decreased oxygen available inside the spinal cord, more spinal cord hypoxia, and decreased energy production as well. And so that's what they found was going on 40 years ago. And additionally, here's a study from '93 looking at blood flow to the spinal cord in the context of tethering. And so they took 10 patients with tethered spinal cord of varying causes, and they used a laser Doppler probe to evaluate spinal cord blood flow under hemodynamically stable conditions. And as you can see here, the flow graphs before untethering the patient and after a tethered cord release, you can see that the blood flow increased dramatically to the area of the spinal cord that they were studying. And they quantified this in terms of blood flow after the untethering procedure. There was an improvement in spinal cord perfusion. And so this was a nice review paper by Nick Theodore and Hal Recate from Barrow at the time. And what they determined really and stated was that the traction and elasticity of the spinal cord is a fundamental factor that underlies tethered spinal cord pathogenesis. And one thing is that the symptoms associated with tethered spinal cord in isolation, they really exist at the caudal end of the spinal cord. It's really sort of sacral level functioning or lower extremity functioning. And this is because the dentate ligaments which are the PL extensions that attach the spinal cord to the thecal sac at every other level of the spine don't exist in the lumbar spine. And in the normal situation, there's been described about a 7% change in length of the spinal cord itself between flexion and extension that may be reduced in a tethered spinal cord situation when you have a tethering pathology. And so oftentimes our patients complain of that worsening back pain with flexion. So in summary, from a pathophysiological standpoint, the spinal cord stretch results in decreased oxidative metabolism of the cells in the spinal cord and decreased blood flow, which leads to impaired function of these neurons and essentially spinal cord dysfunction. So let's look at this case, a 15-year-old girl with myelomeningocele that was repaired at birth, and she did well for most of her life. She was highly functioning, playing sports, but then developed progressive back pain and lower extremity paresthesias. She had fairly normal urination, but this image here, which suggests a tethered spinal cord, but again, it's always going to look tethered, so it's a clinical diagnosis. And in this situation, with the symptomatology and the imaging and the history, it was very reasonable to recommend a tethered cord release to go in and microsurgically unstick the spinal cord and free it up from its abnormal attachments. The intraoperative course from this esteemed surgeon included comments about significant scarring around the neural plateau that was present, a very challenging untethering, highly scarred in spinal cord, very scarred into the dura, but at the end of the operation, reasonable success. And we do this with neuromonitoring with nerve stimulators and bulbar cavernosus reflexes and sphincter monitoring and such. And the cord was felt to be looser at the end, and it did relax into the spinal canal. But then take this patient 6 months later, there's worsening bladder dysfunction, new numbness in the lower extremities, and neuropathic pain that seemed worse despite the initiation of gabapentin, seen by a urologist, and urodynamics demonstrated an atonic bladder, and now she needs to catheterize in order to empty her bladder. So because of persistent symptoms, the patient returned to the operating room 10 months later. Another stressful surgery, recurrent scar had to be dissected off of the spinal cord under high-powered microscopy, and the dura was significantly scarred, but we were able to get a good closure. And these patients get low-pressure headaches after surgery sometimes. We have to keep them flat in order to protect and repair on the dura. And she was seen in follow-up but improving. Here's an example. This is what we see under the microscope. When we look and do these surgeries and do a direct untethering procedure, you can see that on the surgeons on the right-hand side here, and so left hand is caudal and the right-hand side is cranial, you can see that the spinal cord is reasonably freed up from its arachnoid adhesions on the left-hand side up here. But over here, this interface between the spinal cord or the neural plateau and the dura is quite adherent and annealed. And so with gradual dissection under careful neuromonitoring, we're able to slightly free it up. And then eventually we're able to free it up to this degree where the spinal cord is relaxed. I know it's not a 3D image, but the spinal cord is relaxed from its dorsolateral attachment to the ventral portion of the fecal sac with nerve roots that are present here. This patient had a rotatory scoliosis as well. And so these nerve roots on the right-hand side look a little bit more dorsal for that reason. So that's a successful untethering, but sometimes it can be challenging. And so say this patient comes back 18 months again with recurrent symptoms. So really a vexing problem and a concern for recurrent tethered cord syndrome. And in some cases, this can occur in these patients. So it's quite frustrating. So how do we proceed? Do we continue to do the same thing over and over again with recurrent tethered spinal cord? What's the data? Is it Dr. Bowman in Chicago in 2009 published a study in 500 patients with open myomeningoceles. 71% of them underwent at least one untethering procedure, and about 30% underwent multiple untethering procedures. Another study looked at patients who underwent tethered cord release. About 8 out of 89 patients had postoperative complications. You can see some of the complications are listed there, 3% CSF leak there. But having said all of that, even when the patients were not completely untethered, most of the cases had positive outcomes, especially in terms of pain. A study out of Michigan looked at 22 patients undergoing repeat untethering procedures. A total circumferential untethering was actually possible in only close to 40% of cases, and the complication rate was close to 20%, including CSF leak and possible neuropathic complaints as well. So with that in mind, recurrent tethered spinal cord is a frequent occurrence. It's fairly common. We see it especially as pediatric neurosurgeons, and as these patients are living longer lives, these patients are transitioning into adulthood as well, and these are problems that we must face. And so each surgery that we do, which is a direct untethering, we're encountered by increasing risk with CSF leak, neurological function, especially sphincter function. There's generally thinking a law of diminishing returns with these patients. And so are we just playing whack-a-mole here and just trying to live to fight another day with a fairly high complication rate, with more scar tissue, more arachnoiditis each time we do the surgery? And we know we need to relax the spinal cord into the ventral portion of the fecal sac. And so this can be a pretty vexing problem for surgeons, no matter how skillful they are. And again, our tenet as doctors is to attempt to do no harm. And so that's why we've investigated other things. But again, the traditional manner of untethering procedures is a laminectomy, identifying the normal dura and continuing down into the region of distal scar tissue. But you can see what can happen here with multiple repeat laminectomies. You can get a post-laminectomy kyphosis, as this patient has here. And this patient actually required a fusion procedure that was complicated by infection, required implant removal, flat back syndrome, and now you can see there's a sagittal malalignment when this patient gets to their adult state. And so you can see some of the problems that we might face with recurrent tethered spinal cord. And so the concept of a spinal column shortening was proposed by Dr. Kokubun from Japan, who proposed a 3-column osteotomy in 8 patients with lipomyelonmeningoceles. He published here. I believe the original publications were in the 90s, but this one was from 2011. And all these adult patients had lipomyelonmeningoceles with low-lying spinal cord or neural placoed. And the focus here was to perform the surgery at the thoracolumbar junction where the shortening osteotomy was performed, which was a 3-column osteotomy, which utilized screws above and below the site of the osteotomy in order to stabilize and compress the spinal column and actually shorten the spine itself and give it more slack. So I'm a simple person. I like to think about things in simple terms. If the spinal cord is stretched out like a rubber band, we could go in and try to unstick it from its distal attachments to give it more slack and room, which is the traditional untethering procedure. Or you can just decrease the distance between the 2 ends of the spinal cord and hopefully give it more slack. And so that's what this shortening osteotomy is intended to do. This is an illustration from Dr. Theodore's paper and a beautiful illustration from Ian Sook at Hopkins, who's demonstrating this surgical concept that rather than performing an intradural dissection of the spinal cord itself at its site of abnormal attachment, you can go down and do this surgery away from the area of spina bifida and perform a 3CO and relieve the slack on the spinal cord itself, which they're demonstrating in this diagram. So some general principles for a spinal column shortening, and a potential candidate would be to start with some standing x-rays. You want to understand what this patient's alignment is. The goal again is to avoid the area of previous spina bifida. That's the whole point of doing this surgery. Then the 3-column osteotomy is generally performed close to the thoracolumbar junction. Typically T12 is the level of vertebrectomy that's most commonly performed. And the reason for this is because that's a relatively straight portion of the spine. It's the inflection point between a thoracic kyphosis and a lumbar lordosis. So you minimize the chance of an iatrogenic malalignment that could be created with a 3CO. And so generally speaking, choose that straight segment of the spine. Here's what I'm highlighting here, these vertebrae at the thoracolumbar junction. The goal would be to perform a 3CO with adequate stabilization. So 2 up, 2 down is generally the rule. Based on some cadaveric studies, the amount of shortening would be about 15 to 20 millimeters of shortening. And so generally speaking, that involves taking out the disc at one level, and a near complete vertebrectomy or a complete harmonious 3-column osteotomy can be performed that achieves this type of shortening. And in general, going slow with the shortening when you compress on this construct in order to avoid dural buckling and dural kinking, which can kink the spinal cord and lead to a neuromonitoring event. And so this is what we're looking at here. Here's the remnant T12 vertebra in this patient who had a shortening osteotomy performed. The pedicle is gone, and you can see there's likely bone-on-bone contact there after the shortening. So here's another artist rendering of what this surgery entails. It's a laminectomy that's large enough and extends sometimes an entire level above and below. Generally speaking, costotransversectomies are performed bilaterally to allow adequate triangulation to underneath the spinal cord, right, in order to provide ventral bony decompression, because if you don't remove the entire posterior wall of the vertebra, there could be dural buckling and kinking. And so it's important to make sure that you fail that posterior vertebral wall. We've avoided the need for nerve root sacrifice in these cases. And I think that may lessen the chance of an RD of a Danfowitz issue or a watershed thoracic spinal cord issue, but I think it would be safe as well if a nerve root needs to be sacrificed in this region. And a good rule of thumb is to go from the end plate above, so essentially taking out the T11-12 disc, down to the bottom of the pedicle at T12, which will produce around 20 millimeters of shortening. So here you can see intraoperative views of what something like this may look like. A pre-shortening image on the left, and after sequential compression on either side, you can see utilizing a construct-to-construct compression with an outrigging rod. I think dual-headed fixation is very useful in this situation to stress shield your screws and provide a construct-to-construct compression, and constantly checking and rechecking for any evidence of dural buckling with a Woodson or other instruments. And you can sort of feel an increase in the patullousness of the dura as you do this shortening. And you can see that the laminectomy gap is closed. Over here, you can see that the pedicles have been drilled down and the whole vertebra has been removed here. I will generally go through the anterior cortex of the vertebral body, but I will leave the anterior longitudinal ligament alone. Some might feel otherwise. So here is an ultrasound. I think this is very useful to sort of see intraoperatively real time what's happening on an ultrasound. Here's a transdural ultrasound, so you can see that we're visualizing the fecal sac here and the spinal cord, and its dentate ligaments which attach the spinal cord to the side walls of the dura. And with each heartbeat, you can see a certain amount of pulsatility, or actually lack thereof, pre-shortening. And post-operatively, after we've done the shortening, here's what an ultrasound might look like with an increase in that pulsatility of the spinal cord. And you can see the dentates are still holding the spinal cord to the side walls of the fecal sac, but this spinal cord looks a lot happier in its pulsatility, and we can actually utilize the Doppler feature and show increased blood flow through the spinal cord as well. And there's been a lot of interest in this recently with intraoperative real-time ultrasound. Nick Theodore's group's looking at elastography in addition to blood flow. And I think this is important because when we look back at our tethered spinal cord pathogenesis, spinal cord blood flow and pulsatility is an important feature of why these patients are symptomatic in the first place. So this is a correlate that we can see real time as to what's going on with these spinal cords that are a lot happier after a spinal column shortening. So here's a pre and post-op results, standing x-rays, long cassette films here, whole body x-rays. You can see that the patient continues to maintain reasonable frontal and lateral alignment here. I typically will utilize a multi-rod construct across a 3-column osteotomy here in these patients. So just to tie things into deformity a little bit, and I know we're running out of time, so I'll go quickly. The concept of shortening the spine to protect the spinal cord is not new. And so if we look at this patient with a severe scoliotic curve like this, the answer is obviously not distracting on the concavity of the curve here, which could lengthen the spinal cord itself and cause a spinal cord stroke, actually, with ischemia. You assume there's a type 3 spinal cord at the apex here. That is not the right answer here. The answer is, and there's your type 3 spinal cord. The answer here is compression on your convexity, which is much better tolerated and safer for the spinal cord, especially when there's a sick spinal cord that's at high risk. So some shortening outcomes. Nick Theodore and his group have looked at this at Hopkins and Barrow, looking at 20 adult patients. You can see that there's a great improvement in the pain symptoms, but the bowel and bladder symptoms are about 50-50. And so that's what we say to these patients when we're counseling them, when we're considering such an operation, that you can expect likely an improvement in your pain symptoms, but in terms of bowel and bladder symptoms, it's a little bit less certain. And Andrew Jay's group, looking at 41 adult and pediatric patients with a pretty wide age range. You can see 5 to 55 years of age, all with a secondary tethering pathology, 91% subjective pain improvement, 50% again urinary improvement with some objective improvement with the urodynamics. The complication rate were 2 for intraoperative blood loss, 1 small durotomy. I think that these are reasonably acceptable. And so what are my indications for a spinal column shortening? Would be a recurrent complex tethered spinal cord. For a patient with a recurrent fatty phylum, I think a direct intradural untethering is appropriate. This is really for some of the really challenging lipomyeloningocele spinal cord lipomas, really difficult scarred in recurrent operations that we know firsthand, especially from the surgeons who've done the untethering. It's always very useful to read the operative notes and speak to the surgeon themselves. Patients who are nearing skeletal maturity, I think, is important because the predictability of the durability of this operation in the skeletally immature is less clear. And no significant spinal deformity above and below. And the family willingness to participate in this journey, because this is a relatively new operation that we're just beginning to scratch the surface and understand this and understand this is a complex procedure. There is a compelling literature for it. There is a higher chance of a transfusion, but there is a possibility of a significant spinal cord injury because we are performing a 3CO in the low thoracic spinal cord. The benefits, of course, there's no intradural work. Yes, there's a risk of a durotomy, but these patients can sit up after surgery. They don't generally experience low pressure headaches. And this may be preferable to the very high risk pathology that's present. And in the skeletally mature individual, I believe that this surgery is likely durable. And in addition, we're avoiding the previous scar and previous incisions that have been made. So in this particular example, you can see a large pseudomeningocele that's present on this patient. I don't think anyone has any desire to go back in and operate in the lower lumbar spine on this patient here. And so some questions still remain, of course. Is this safe and effective in the very young? What is the durability in the immature spine? And also fusing the young spine. What's the consequence of that over the years, 30, 40 years down the line? We don't have that data. The long-term outcomes are less well understood. Again, the need for possible transfusion, it's a longer surgery, it's complex, so you need experienced hands doing this type of surgery in order to do a 3-column osteotomy. And in addition, we need to understand also that the tried and true surgery is a direct spinal cord untethering, and in general, there are good outcomes with this surgery. So we had a chance to write this editorial. Are we tethered to the past no more? There is a role, I think, for spinal column shortening, especially in the recurrent tethered spinal cord population. And I think it's important to have another arrow in our quiver as we treat this complex patient population and treat these patients on an individual basis. But I do think that in the right situations, in the right hands, with the right patients and the right families, that there is a role for this operation in some individuals. And so I'd love to take any questions. I'm sorry if I went over by a few minutes. I'd be happy to take any questions. This is my email, and thank you so much for the opportunity to speak to you today about this topic.
Raj, on behalf of everybody, thank you so much. That was a really spectacular presentation and super interesting topic that is so overlooked. We have had very favorable responses from around the world, especially shout out to Dr. Ahmad Farad Pirzad from Afghanistan and Tasha K. Walker Palmer, and I mean, just many, many colleagues. So really overlooked. One more time for a slow brain like myself. The fatty phylum, that famous entity, do we clip that first if we are truly convinced that this patient has a tethered cord, or do we go to T12 subtotal vertebrectomy shortening of the column? What's the paradigm again to kind of pursue?
You're referring to a recurrent tethered spinal cord with the tethering pathology being a fatty phylum. A fatty phylum is really commonly found. It's a controversial topic even to untether those patients in the first place when they're infants. It's a topic of constant discussion in the pediatric neurosurgical community. There's about a 7% rate or so, maybe between 5 and 10%, I'll say, of a recurrence of that lesion. And on the spectrum of tethering pathologies, a tight phylum or a fatty phylum or a fibrofatty phylum, all of these things refer to a fairly straightforward tethering pathology that requires about a 45-minute to an hour-long operation for a fairly straightforward and low complexity operation to clip that phylum and untether the patient. So with that background, I would say that a recurrence of that lesion warrants likely a direct spinal cord untethering rather than a spinal fusion, which is complex, 3-column osteotomy and a fusion in a young individual. So I would favor in a fatty phylum that's recurrent to go back in. We actually did one last week to go back in and do a direct microscopic neuromonitoring guided untethering.
Tariq Sohail from Lahore, are you live? Can you talk? If you had any reflections. Hi,
Yes.
nice to see your face. Tariq, tell us your
Yes.
thoughts, any questions. We have to kind of come to a close shortly, but what did you think?
I think it's a very
What
interesting
questions do you have?
talk. What precaution would you advise us or give us some precaution what to take in treating adult or in evaluation and treatment of adult tether cord syndrome because of either trauma or because of previous surgery? What particular because it's entirely different ball game altogether as compared to what you see in a child or a newborn baby and with a phylum terminale or some other tethered cord because of the traditional tether cord.
Thanks for your comments, Dr. Sohail. And, I think in adult tethered spinal cord, we're seeing a lot more and more of this across the world, it sounds like, and especially as the myelomeningocele spina bifida patients become adults. Because despite the fact that they become adults and they're done growing, we still see tethered cord in the adult spina bifida population. And so I think it's really important to drill down the basics in these patients. What exactly is going on with them to make sure that we have a clinical diagnosis of tethered spinal cord, because the imaging is not the answer here. The imaging is just going to confirm your suspicions. It's just like if I image a patient's shunt when they're 25 and have never required a shunt revision, you're going to see shunt fractures, but that does not mean you're posting them for the OR the next day to fix the shunt. So you have to have a strong pretest probability of a tethered spinal cord before you get that imaging. And I think it's important to understand that there are different etiologies of all of this: infection across the world, post tumor resection, tethered cord, myelomeningocele. And I think that, my default would be to do a direct spinal cord untethering. But in situations where it's extremely challenging and you think that neuromonitoring events are going to occur or have occurred, those are the patients in whom I think that this particular solution is very compelling. And I think it's in the recurrent tethered cord population who have had previous direct untethering. And in the adult population, I think my threshold for doing a surgery like this gets a little lower and lower because you can avoid that scar tissue in the low lumbar spine, avoid the chance of a CSF leak, avoid the chance of an infection, which becomes, I think, increasingly likely as these patients unfortunately decondition over time. They get larger, their BMI is larger, their infection risk goes up. And so these are a lot of considerations. And I think that we've had some success, I think, in the adult populations, and that's what the literature has borne out as well.
When you're shortening, do you consider shortening in adults, and do you do at the same level of pathology or a little away from pathology?
Yeah, so let's say we're dealing with a lumbar, level plateau,
Usually in the lumbar.
L3, L4, say a classic example, and the patient's had multiple untetherings in the past. The goal would be to avoid the previous scar in the lumbar spine, focus on the thoracolumbar spine, either 3 up, 3 down, 2 up, 2 down, dealer's choice in a way. Depends on other things as well, other considerations, patient's bone health, things like that as you get into the adult stages and phases. But generally speaking, the T12, L1 levels are the most common sites for the vertebrectomy. Reason being is because the spinal cord below, there are no dentate ligaments. And that's generally the last level where you have dentate ligaments attaching the spinal cord to the thecal sac. So I think there's an elegance to the adult version of this operation. This is where it was originally described by Dr. Kokobon and has been borne out in the literature and our adult colleagues across the country here. We've sort of expanded the indications into the pediatric population, but I think the adult population is really where there's a lot of promise to this operation.
So this is a great talk. We have to come to a close, but I want to just
Thank you, Rajiv.
Thank you.
thank you for this great lecture and overview. And I think the haunting, the insightful image that will last with me was the ultrasound before and after comparison. I hope that all viewers will really keep that in mind. It was so compelling. It goes beyond tethering of the cord to the severe kyphosis disorders or the abutted and compressed spinal cords. The perfusion and the nice CSF water stream around the cord being so important for a healthy cord was very compellingly demonstrated by you. So really thank you so much for sharing your insights and the beautiful visuals. And we had over 200 viewers live. So this was very, very cool and nice resonance around the world. Great effort from you, and thanks for this wonderful event.
Thank you so much for having me.
Thank you, Jens. Thank you, Rajiv.